Hey guys, I went live. I'm hoping that this worked so that I could start this. But if you guys can see me, can anyone say something? I don't hear you guys at all. Hold on. I see you, Casey. I see you, Carolina. But it does say we're live for 37 seconds. Hold on. Let me see what I can do, guys, because this is kind of a nightmare. I got stuck in DC, or I'm on my way to DC and couldn't do anything. But looking at my private chat, it has. Okay. It says I can add you guys to the guest. Alice, I see that you've joined and all these people have joined. I am literally just trying to pull people on, but I am on a plane. Hold on. Casey, do you know how to do this? Hold on, guys. Oh my God, I'm so sorry. This is a nightmare. I see all of you coming, so hold on. I'm trying to figure this out. I usually do it from my phone. I am now from my computer. I am on a phone. So hold on. Let me see if I can. This is not. Let me see my guests. You guys are all here. Casey, can you see anything, or do you see how I can add this? Thanks, Hamish. It was a settings issue with Casey. I don't know. You guys, can you see me? Let's see one more chat in our private chat. You can see and hear me. You have no controls. My goodness, you guys, I apologize. I did not plan on being on a plane when this all went down. I am looking and trying to see where it says on these buttons to let me in. I'm just going to try a desktop site, but I see all of my guests here. I just do not see here on my phone how I'm supposed to do this. Okay, I'm back, you guys. I am not sure. It says I have 5 guests in here. We've been on for 8 minutes. Noor, hi. I am literally just trying to figure this out on an airplane from my phone. If anyone knows how to use StreamYard from a phone, that would be absolutely amazing. Just click on each of us and allow you in. So I am going backstage. Here's my guest, Hamish. Oh, that was how it was. Okay, guys.
I'm in the show.
We
Hey,
got this. We got this. You got this. You got it. All right, Carolina and Hamish, turn on your freaking cameras. Come on.
My camera is on. I've got 2 devices here. Can you hear me?
Well, I can hear you, but
I can hear you. So Stella, are you in as well?
I've got a second device, and that second device has my.
Okay.
It's called
my apologies.
No, hey, look, this is figuring it out on the fly.
We'll get there.
We got.
Good morning, everyone.
Good morning, Carolina.
Buenos dias.
Hello, everyone.
The good thing is that we're all very connected and eager to start.
Yeah, we're all here, so yay. Well,
can you hear me all?
I
am going to
Willy drop off.
Yeah, Willy. I don't see Willy there, and I don't see my webcam either.
No.
Oh, here's Willy. Hold on.
Go into settings.
Hi. Can you hear me?
Yes, we can, Willy. Hello,
we
Willy.
need to see you too, though. That would be fun.
Hi.
Turn on your camera, buddy.
I was not supposed to be on a plane, you guys, so I'm going to apologize right now to all of you. And I am going to leave this on and leave the room for a minute while I get off the plane. But I just wanted to, before we all start, I brought Estella on to kind of moderate in my in my absence and while I'm on the plane, but I wanted to really just bring you guys all some of the amazing companies and things and people that I meet and I see out in conferences. And Hamish is one that Casey and I really like. Casey has been one of the ones that have brought it to my attention. There you go. And I just want you guys all to also see what's out there and what the options are for us as patients in the future. So Estella, I am going to go on mute and off my camera for a few minutes. If you want to kind of go through a whole intro and start a conversation, then I'll hop back on in a second. Sound good?
Yes, perfect.
We got this.
All right. Okay. I will be back. And thank you all for joining us. So I'm on a plane. I'll be back.
Yeah, she's on a plane. She's going to get off a plane and then we'll see her again. It'll be awesome.
And then you'll see me again. Okay, yeah, bye guys. And Estella, go ahead.
Just don't forget to leave your phone on. Anyway.
Good morning, everyone. Good afternoon, everyone. Thank you for joining. This is People with Empathy. And, sometimes there are technical difficulties. If that's one of the things we've learned throughout this pandemic is, things can happen. And unfortunately, it happened to us. But we're all here today and we're excited to start this amazing conversation that I think it's long overdue. And so we're going to go ahead and go in a circle so we can, I'm going to start with whoever's on my right, and then you introduce yourself and then we can get started. I will start. My name is Estella Mata and I am a co-founder of Looms for Lupus nonprofit organization. And we work so closely with Christine, and I know most of the people here. And so I'm happy to step in and moderate. So Carolina, would you like to introduce yourself, please?
Hi, everyone. I'm Carolina Consuegra. I'm part of People with Empathy. And as Stella said, we have to show our empathy and know that technical problems shit happens. Oops, I just said
That's
that
all right.
online.
The FCC isn't here. We don't need to worry.
Exactly. So anyways, I am part of People with Empathy, and I'm also co-founder of a communications company that dedicates itself to translate science to people. So that's also why I'm here. Now, I feel like what was the show that the people were the Brady Bunch. Yeah, no, Brady Bunch. So
the Brady Bunch. Boy, that's going back a minute. I think I'm the only one here old enough to have seen it in its first run. But anyway, I'm Casey Quinlan, known as Mighty Casey on the interwebs. I am a longtime journalist, have been a member of the breast cancer social media community since it started, really. My first diagnosis with breast cancer was back in 2007. I wrote a book about managing medical care based on that experience. And I now, because I'm just that lucky, am in the 30% of people who are diagnosed with early stage breast cancer who get to have a metastatic breast cancer recurrence. So I was diagnosed with metastatic breast cancer last year. And so I'm navigating that journey now. But I'm dedicated to patient-driven research and putting people as well as clinical researchers, payers, policymakers, et cetera, but bringing the citizens on board to help drive research and better inform research, because I think that we'll have better questions and we'll also have better outcomes. So that's why I'm here.
Thank you, Casey. And Hamish?
Yes, it's Hamish here. Can you see me yet? I think Christine's going to have to let me in on my second device.
Oh, that could be it. Yeah.
Yeah. I've got, so this is my audio device, and hopefully Christine's able to bring me in on.
Well, we can hear you, and that's the important part.
That's the important part. So Hamish MacDonald, I am the CEO and founder of the Sovereignty Network, which briefly can be summed up as an economy for patients and those who serve patients, which is the opposite to how healthcare usually works. Looking forward to talking about that today. Mighty Casey is a fantastic supporter from the patient side with us, from the patient advocate side. We want to do a lot more with them, patient advocates of all stripes. And we also have Willy Soriney calling in from Nairobi, Kenya. Now, Willy is very interesting. He spent many years working for Pfizer as their head of sub-Saharan African strategy. So he knows all about the difficulties and the opportunities with research in general. And we want to be able to get a trial going in Nairobi as soon as possible. So, Willy, I'll use that as the introduction through to you. Thank you very much for making the call over in the evening time in Nairobi.
Thank you very much, Hamish. I wonder whether everyone can hear me well.
Yes, we can.
Yeah, hear you fine.
Excellent. I am really, on one side, very amused to be in this discussion, but also very happy and excited. The reason I'm amused is I'm asking myself, why didn't this kind of engagement happen before? It is what needs to happen to ensure that the right solutions are developed at the earliest opportunity better. So as Hamish has mentioned, I have been in the pharmaceutical world for close to 25 years. I am based in Nairobi. I am a Kenyan. I work with AstraZeneca, and then I work with Pfizer. All these names have become very prominent as a result of the Guess Who, which is called COVID. And I held various roles in the two companies. But the roles I cherished the most were the ones that we were trying to build bridges to work with patients, directly establish common resourcing opportunities. And the last role I held was Director for Strategic Partnerships in Sub-Saharan Africa for Pfizer. And that held a role for strategy, as well as a Director for Strategic Partnerships. I was more or less an ambassador of Pfizer into the communities, where trying to scale up health innovations, trying to raise the voices of patients and patient groups, trying to bring more focus into specific issues and health problems. And I did that for close to 6 years. I think it's the role I enjoyed the most. And then I left Pfizer last year. Now, I joined Hamish as a board member of the Sovereign Network. And I find that this is probably the last missing piece in connecting up the solution providers and those who require the solutions. And for anything I mentioned today, I will not be representing any company specifically. I'll just be relating the experiences that I've seen on both sides of the stream, and the opportunities that can be worked on to stimulate further gains for both sides. Thank you.
Thank you, Hamish. Okay, I'm back. I'm in a nursing room.
Hamish says let him in on his second device too, so we could see him.
Hamish, you were there on a second device, and I figured out how to do this on my phone. So we're getting it, guys.
Hey,
but I wanted to, and there is the actual real Hamish there. So guys, I wanted to say, first of all, you all know I've been out to a lot of different conferences and all these different places, and I'm seeing a lot of things out there that could help patients. But a lot of these things also aren't getting enough attention, and we're not hearing about them. And so I really wanted to take this opportunity, because I don't know if any of you got a chance to look up at Sovereignty when we posted this. But Hamish, I want you to tell a little bit about Sovereignty, why this started, and then Casey and Willy, I want your thoughts too, right? Because I think a lot of times in this industry, we don't look at things from different perspectives. We tend to see things from one, and then we go with that. So I would love to hear from you guys. First, Hamish, a little bit more about the network, and then Casey and Willy, what your thoughts are and how you think that these could help patient communities, because I see it as a very good thing, and I'd like to hear your thoughts. So Hamish, do you want to start out, and then we'll go back to Casey, because we really want to, we're broadcasting this live on both LinkedIn and Facebook. We want our patients to see, but we also want the industry side to see as well. So that's your general audience, is really just a mix of everybody that's in my life. So I guess the basic way to explain it would be layman's terms for everybody, if you can do that, Hamish.
Sure, I'll kick this off, and I'm so glad that Casey and Willy are on the call, because they represent both sides of the equation, both industry through pharma, through R&D in general, and patients represented by Casey. So soon I'll pass off to both of them to give their perspectives, and I think everyone listening will get a lot of value from understanding why they're both, from their respective sides of the equation, so excited about the marketplace we've created, which it is in fact a marketplace. It's a marketplace where patients, what we call data owners, are in charge. They're deliberately called data owners because every piece of data they put into their sovereignty account, they own as a personal asset. And what that means is the way we've set the system and the marketplace up is that since everything is coded, and I'll keep this non-technical, but there are codes like SNOMED and FIRE out there that allow a whole lot of machine computations to happen. And effectively, it allows an individual to create their own electronic health record, not just a personal health record, their own fully coded clinical health record, not just for clinical things, but also psychosocial, lifestyle, environmental, even genomics, all the things that inform your clinical. So as you create that, for free in the Sovereignty Network, we're able to take those codes that you didn't even know existed, but you've entered. You have, let's say you have cancer, for example, a few years ago. You put the date in. Well, there's a code for that, and then we can make those codes available, anonymized, to researchers on the other end of the marketplace who are able to literally build a cohort live at their desktop, even on a Saturday evening if they wish, something that they can't do right now. They can say, right, I'm looking for patients who are female, have breast cancer, maybe have been on this medication, this treatment, but I want to exclude people for whatever reason, making this up. I want to exclude people who have hypertension. I want to exclude people who have used this medication. I just want to search for these particular criteria. Well, our system is able to do a search amongst all those criteria, find the 74 or however many it is that fit that particular criteria, and now the researcher is able to send out an offer. Because remember, the data is owned by the patients, by the data owners. They send out an offer. It could be for a survey they're looking to take place. It could be for research. It could be for a clinical trial. It could be for real-world evidence. So then the researcher is able to send out that offer. And if each of the data owners accept, yes, I'd like to be part of that, they get paid by the data researcher to partake in that study, do that survey. So you're actually getting paid for your own electronic health record under your control. You partake of it if you wish or you're not. You still remain anonymized even if you've taken the survey. It's totally up to you whether you identify yourself or not. But we have a crucial mechanism in the middle called a data coach, and that's the final participant, and that's clinicians or board certified patient advocates. It can also be healthcare programmers who verify the pieces of data the researcher is specifically looking for in their set criteria. And so that's what provides the validity and the level of comfort for the researcher to be able to, on their desktop on a Saturday night, dial up a patient cohort, find out there are people that fit, send out an offer. The patients or the data owners take up the offer. The patients and through the marketplace can verify the key pieces of data they need to be able to partake, and bang, away you go. You've got a patient-driven, patient-led, patient-owned economy, but we're also on the other side solving a huge problem for researchers in trying to easily, cheaply, without the hassle, find people who can fit their next survey, fit their next research, fit their next clinical trial. That's the Sovereignty Network in terms. I hope that was easy enough to break down audio-wise how this works. Let me know if you have any questions about that, if it didn't make sense.
And Hamish, I want to comment too before I move over to Casey, and this is for the patients who are listening out there as well. I'm on Social Security disability, and so I am not allowed to make money to keep my health insurance. I'm sure you all know how that goes. But we've been searching for ways to really democratize data collection and ways that people like us who may not be able to work could then get something back for the information that we're providing. And so I like to explain it as my data is my song. And if you want to play my music, you've got to pay the royalties. And so I just kind of wanted to put that, because Hamish, I love you to death, but kind of a little out there for that patient side of it. But when we look for clinical trials, we have to look for specific groups, right, in order to make these drugs really work. And you have to have very small populations that are very, I don't know, someone help me with the word. Like, I'm not thinking because I just got off the plane, but really just
very targeted as to condition and, diagnosis. And then the underlying, as Hamish put it, codes, depending on, you could be talking SNOMED, which is more of a health IT function. And then there's the ICD-10 codes, which may or may not be familiar to the average patient out there, but those are the diagnosis codes that are attached to billing. So there's a few different code sets, but they're all describing essentially the same thing, just slightly differently depending on which direction the codes are going in to create a record or create a bill, etc.
Perfect.
Like
and Casey,
I'd
go
like to
ahead.
actually, if I may, to fully answer what you just mentioned before, Christine, I'd like to pass back to Casey again, because we are right now undertaking a very specific, very targeted group of patients to do with breast cancer, something called HER2. And I think that answers your question, Christine. I'll pass back to Casey to describe. This is in the New York Times last week. It's a hell of a breakthrough, and it's something we can very quickly help breast cancer sufferers be able to meet researchers, be able to get the treatment they need. And I think for other people who have other conditions listening to this call would be interested to see how this could apply to their own situation. Over to you, Casey, on HER2.
Right. Well, as I mentioned before when I introduced myself, I am a breast cancer patient. Lucky me, I get to do it twice. I did it once, and now I do it with metastatic breast cancer. Yay me. Now, there are a number of types of breast cancer. This is, I'm going to keep this from getting too clinical. The types of breast cancer are, the most common type is what's called hormone-driven. It's driven by estrogen and progesterone, and something about your cells react to perhaps a little bit too much estrogen or progesterone in your system, which causes cell mutation, which in turn causes breast cancer, called hormone positive or ERPR positive. That's the type I have. And as I said, it is the most common type. Other types are HER2, which is a protein, and that is driven by reactions of cells to what's called an overexpression. In other words, you have a little too much HER2 running around in your DNA soup. And as a result, that can cause cell mutation and cause HER2 positive breast cancer. Then there's NEU. I can't remember what that's short for, but there was a drug that that really helped patients with that type of breast cancer back in the 90s. And at one point, I can't remember which pharma company it was. It really isn't important for this story. But a number of women who had this type of breast cancer, the NEU-driven type, chained themselves to the gate of a pharma company to say, we want early access to this, FDA, give us the drug. And they ended up getting it. And a lot of women benefited from that particular drug. So we have hormone positive, HER2 positive, NEU positive. Often HER2 and NEU run in parallel. In other words, you'll have both. So it'll be HER2 NEU positive. Then there's what's called triple negative, which has no hormone driven, no HER2 driven, no NEU driven. That is one of the hardest to treat because typically treatment will be aimed at whatever it is that's overdriving, causing the cell mutation, be it hormones, estrogen or progesterone, or both, HER2 protein overexpression, or the NEU, whatever that stands for, overexpression. So you've lost the things you can, the guns you can aim at those four things. And so now you have to try and figure out through, trial and error, what might work with this for this person who has triple negative breast cancer. Now, there's also the little extra sauce, what I call the DNA lottery winners joke, where you have a mutation on either your BRCA1 or BRCA2 gene. This means that you have a hereditary higher risk of either breast or ovarian cancer, in some cases both, depending on how much of a mutation shows in your genomic assay of BRCA1 and 2. And you are at risk for breast cancer and or ovarian cancer, or both, as I said before. And there are vibrant communities online that are both helping people with resources and understanding genomics and finding genomics counselors, and also very nerdy groups who not only are BRCA1 or 2 genetic mutation carriers, but they're also nerds extraordinaire, and they have dived in on understanding a lot of the genomics behind it, and also trying to drill in on some of the other results within their genomics to determine whether or not, what their risk might be, what action they can take on their own behalf. And, so there's a lot of people out there who are talking about all of the things I just mentioned, all the types of breast cancer, plus hereditary risk of breast cancer. Now, one of the biggest frustrations that people who either are facing a known risk or who have gotten a diagnosis of breast cancer is it does feel as though it's a complete crapshoot whether or not you get access to the highest and best and most recent discoveries in science. It depends on your oncologist, what their level of knowledge is, what their network looks like, how much reading they do, how involved they are with the research community. And at some point you do kind of just have to surrender to the process. But say you have a breast cancer diagnosis and the first line or even the first couple of lines of treatment that your oncology team uses doesn't really deliver the results that would be good for you. In other words, it's not stepping on progression. It's not stopping the disease. It's not, bringing you to the point where you can say no evidence of disease, which is the goal for all cancer patients pretty much. And that frustration has been, driven because we don't feel as though we, the patients, have that much access. Those of us who do read journals, who are hooked in with the research community, certainly have a little bit better shot at getting more, sort of early stage, getting access, early access to treatments. But it should be a flatter landscape for everyone who gets, well, in this case, I'm talking about breast cancer, but throw any disease, lupus, it can be anything, throw anything in here. Now, here's where Sovereignty Network comes in. Now, I have for years been shouting about the utter inequity of the data economy, what has become known as the surveillance capitalism economy. In other words, because we're all walking around with these all the time and our computers, and we live our lives online, and this was, sort of sold to us as a way to make life easier, more frictionless, et cetera. Well, yes, it has in some ways made that so. But at the same time, all these giant companies know all this stuff about us because we carry these things around and we're using computers all the time. And on the one hand, that's great. But then on the other hand, I don't know. In fact, well, I do know that Tim Berners-Lee, who who wrote the code that created the internet, did not invent the internet so that we could have better ads targeted at us. He wanted this to become a global communications net that erased the barriers between humans so that we could better understand each other and we could build a better world together. Well, the first iteration, we ended up with an ad tech economy that a whole bunch of people, some small number of people, are making a whole bunch of money off of. The rest of us are all like, well, what did I get? Okay, I got a phone and everybody's sniffing my underwear 24/7 because of the data economy. I'm not liking that. So I've been yelling about that for years. Now, here comes Sovereignty Network, and this is the first time I have seen something that lets me take my health data, which is the most valuable data set that any of us possesses, all of the things that make up us. And, that includes if you do a spit kit for genomics of whatever type, whether it's just for, I want to know what my in other words, what my heritage is, or you do a genomic test because you want to know if you have a BRCA mutation or any one of a number of other mutations that are known to science. But you can take that genomic information, you can take all of the information you have in your medical record, and you can put it in Sovereignty Network, and then a data coach, a clinical professional or some kind of certified person who knows coding for the medical medical and science side of the world, they go in and they vet through it, so everything that you've entered in there has its applicable code so that it's machine readable, and a researcher can come in and say, I want a population of people with insert disease state A with these other attributes, age, or, excluding other things like if they have hypertension, or if, adding if they have diabetes, any one of, any combination of a number of attributes health-wise. And then you basically spit out a research cohort for this researcher who, as Hamish was saying, sometime, they're hanging out in their computer and they're, playing with their iPad, and they come up with a research cohort of 100 people that they can now send a survey to start exploring their research question to see if they have a cohort of people who might, say, fit in a clinical trial, or fit at the beginning of forming a clinical trial, or, coming up with a longitudinal study of a condition. There's just, there's sort of endless possibilities. I think Willy will probably be able to speak to the research side of this, more knowledgeably from actual experience than I can. I mean, certainly I'm no dope, but I speak much more from the patient point of view. I see the promise of this because sovereignty, with the data set that one can put in there, create, and then become part of a cohort of whatever, depending on what your stuff is that you have, whatever that is, that you and the community that you belong to within sovereignty with those same condition attributes, you can decide in your community whether or not each individual is going to get a little something, like say, pharma comes up with, a pharma company comes up with, an ask, and then they get to come in and, the researchers are bonking through and getting their cohort together. Then there's a determination, this is like, either you get paid, $50 each to complete the survey, or the community itself gets some kind of a stipend for the number of people that it contributes to the cohort of a clinical trial. And then the community itself will come up on that side with an idea of like, maybe that's just to keep the community self-sustaining so that it can support the administrative burdens of moderating the community. Because in my opinion, moderators of online communities should be remunerated for the time that they put in. And, and I think that there's also ways to, have that, those stipends pay for people who are part of the community to attend research conferences, to start spreading the word about the options available with their community through Sovereignty Network of research into these various conditions. I see this as a real virtuous cycle that is just getting started with the one, science has been flying in missing man formation since JUMP. It's all been about, the scientists, the doctors, the researchers, et cetera. But the patients, the people called patients, have usually been left out of the formation of the clinical question. And, sort of what should we study that will give the most bang for the time? And I think that now that we are starting to be seeing more patients as viable members of the research community, that sovereignty is a way for us to start to really stand on our two legs and participate as full partners, as opposed to just, sort of random subjects. And I will stop there.
I just wanted to touch on too, because I've had this conversation with other patients, and we're all at a level where we kind of understand this. But I do want people to know that we do not currently own our own data, right? And so the health company, whoever has your data, whoever collected that data, is actually the owners of that data. And so what we're looking at is taking that and taking agency and really, taking that back. And then by being able to offer that as a community, right, to people. Yes. So we're not, this would be us of our own doing, wanting to do these things, right? And so I want people to understand that data issue is a very sensitive issue at this moment, right? We don't know who owns it.
The quote unquote system side, i.e. the healthcare providers, the payers, policymakers are all kind of struck dumb when, they're like homina, when you say patients should own their own data. There are efforts afoot, one in particular that I know of in Massachusetts, being driven by a guy I know at MIT, that would put patients owning their data into the laws of Massachusetts. And because of our 50 state by state routine around things like this, it's going to take, absent federal law, because there is no federal law on this, absent federal law, state laws are going to have to step in and start to codify data ownership by patients across the system. However, sovereignty leapfrogs past this issue and just allows us as patients, people, to build our own, you know, health record data set, which we know we have our records, you know, however you have it. You could have a giant binder and just keep flipping pages and putting things in there, or go into your portal and export, you know, however you choose to do it. You can go in and enter your own data. And then that data set within sovereignty is your asset. You own it. And then you can add it to other people's data in your same condition community, i.e. for me, that would be the breast cancer community. And there is a breast cancer research squad group, you know, community now on Sovereignty Network that, you know, Hamish and I kicked off, what was it, last week when I was in DC, and we were sitting around drinking coffee and trying to change the world. So we created that. And there's now sort of, you know, we haven't started talking about it publicly yet, but there's going to be a survey around this HER2 issue that was revealed at ASCO, the American Society of Clinical Oncologists. Those are the cancer doctors across the United States and to some degree the world. There was a study that looked at HER2. That was the protein overexpression breast cancer type that I mentioned earlier. HER2, you are tested for when you get a pathology result. You will get an assay of, you know, it's hormone positive, it's HER2 positive, it's new positive or not. And, you know, your pathology report will say all of that. Now, it used to be that HER2 having a positive of either +2 or +3 meant that that was going to be a line of treatment that you were going to get. You were going to get something that attacked the HER2 protein overexpression. There may be other things that they were attacking too, because perhaps you were hormone positive too. But anyway, they knew that, okay, that's one we're definitely going to go after is the HER2, because there is we can see that there's an overexpression there. However, they did a retrospective study looking at women who had HER2 low and who were treated with a new HER2 targeted treatment. And these are women who particularly had metastatic breast cancer. And with the HER low, even the, 0 to 1, even with HER2 low, they saw a better result, a better outcome with this additional line of treatment. No matter, even if they had hormone positive and a little tiny bit of HER, they saw a better outcome with the addition of this drug for HER2 than they would have otherwise. And that was huge. That made the New York Times, along with the other colorectal cancer big wow that hit, because 12 patients for a number of years now were completely cured in this one. It was like there were two big wows. One of them was the HER2 thing in breast cancer, and the other was a colorectal clinical trial that people are still going wow over. So there's hope out there. We just gotta do some science.
Oh, go ahead. Casey, I was just going to say, I want to really quick bring it back to other communities as well. And I know we're starting with breast cancer, but I totally see ways that this could help other communities as well. And really just combining that collective data, right? And these groups really taking that initiative to take control over your own group together, right? And really
find researchers to help you and your community and do the studies that will improve outcomes for you and your community with your conditions.
Yeah. And I would love to see Willy. Willy, you've worked in the pharmaceutical side of it. And there may be some oppositions to patients owning their own data on the other side of it. What are your thoughts, since you were in the industry, and now what do you think about this concept, Willy? I'd love to hear from you on that. Are you still there, Willy? Here?
Willy, your mic's off. You got to unmute, buddy.
I know. It's like, wait.
All right. Yes. Sorry. I temporarily lost you, but I think I had a question. The first thing that I'd like to from a very personal
You're breaking
wow.
up a little, Willy.
Yeah, Willy, I think we lost you. Oh, there you go.
Okay. So let me just repeat again. From the full knowledge of the pharma industry, and I'm speaking of 2 decades plus, I do not think there'll be any company that has any problem with the patients owning their data. And this has been going on. The patient data ownership has been a matter of reality. It's just that the administration.
We keep getting that little good part of it, and then you break out, Willy.
Okay. Can you hear me now?
We hear you.
Okay. So let me start again, but more quickly now. Straightforward. No one in the pharmaceutical industry will have any problem with patients owning their data. Presently, they obey all the realities and expectations around patient data and privacy. It's just that the administrator happens to.
Willy, it's in another country.
Willy, wherever you are, pull over because you're driving, and I think that you're driving through dead spots.
Can you hear me?
Yes, we can hear you now. And Willy is in another country as well, so kind of, you know.
Yes, correct. And anytime I threaten to disappear, please raise the flag again. I was mentioning that the pharmaceutical industry is a very strong adherent of privacy and patient data. So there'll be nothing new, and I don't think anyone will object to that. This is from the full knowledge of the industry as I know. Okay, so far so good. Still hear me?
Still hear you. Keep going.
Great. Now, the second thing that my comments about the innovation that is in front of us, I'd like to sum it from 4 perspectives. These 4 perspectives are speed, accuracy, transparency, and connectivity. Let me talk about all those because they impact the way healthcare is provided and especially the way medicine is developed, and the long result of it has a full bearing or impact onto the patient. Let's talk about speed. Presently, it takes between 8 and 15 years, even when things are super accelerated, to develop a good medicine, or even to develop a new dimension of an existing medicine. That is exceedingly slow, and for patients whose disease turnover is rapid, they may unfortunately pass away before anyone even recognizes there is an issue around their disease. And Casey has summed it very well. For the diseases that have very short turnover time, there's practically nothing research can do for them until there is a prolonged period of time of seeing things as an incident until it is confirmed as a statistical reality. Now, the sovereignty network brings in a potential to speed up visibility of every disease, every nuance of the disease, the pace and speed of development of the disease. And this is brought into the attention of researchers and pharmaceutical companies who can set into motion very quick research activities to meet the needs of these patients. Without that, you'll have to wait until you count a certain number of patients to confirm there is indeed a disease of that kind. Anyone who's familiar with the story of HIV knows that someone started seeing people dying of a strange disease. And it took almost 2-3 years before people thought maybe this is a viral disease. Previously, it was called a gay syndrome. Now it became a viral disease, but it took 3 years before that could be nailed down as an actual disease. Imagine if you had a patient community that is also engulfed in a healthcare community that is on a day-to-day basis, in a live perspective, able to bring out these new healthcare scenarios very quickly and bring it to the attention of academic people and researchers. You'd have a very rapid turnover of solutions to deserving situations. Now, that speed is not present at the moment, and lack of speed heavily disadvantages the patient. Now, let's go to accuracy. If you look at any research now, as Casey put it very well, if you were speaking Swahili, we would call it patapotea. Patapotea is a simple translation, means you get it, you lose it. I mean, there's no absolute certainty that you will gain, you might lose. Because the accuracy requires that for research to deliver good medicine, for example, accuracy in identifying sufferers of a certain disease in all the dimensions necessary. Like, for example, what Casey has outlined, the various shades of breast cancer. If you cannot accurately nail those down, you will just develop a general drug that may treat some and may not treat some. This is the case with, let's say, breast cancer again. For decades, tamoxifen was the gold standard in treatment. And unfortunately, a large percentage of patients were not covered by that because research didn't know there were other shades of cancer, breast cancer, that needed to be addressed. But as this knowledge became clear that there are various differentiations in breast cancer, a new problem arose. You couldn't tell who has that different shade versus the other one, and unless you're able to round up all the patients and ask them or track them down, you do not know. You are just hoping. Sometimes people would say HR2 positive cases are 30%. Now, research can disprove that or prove it. But with the sovereignty network where the entire patient community can be online, it can just become a matter of clicking and asking a question, and instantly you get an accurate result, and you can follow through your research based on the accurate tracing and working with people with that problem. The pharmaceutical industry has never been this lucky. It is probably the golden bullet that they would wish for, to say, we would like to research into epilepsy, but now we want to talk to people above 50 with epilepsy. We want to talk to smokers above 50 with epilepsy. We would like to talk to smokers who stopped smoking 3 years ago specifically. The pharma industry does not have that absolute situation now, and it is the basis of developing medicine in an accurate way. It will cut down on time. It will cut down on costs. And matter of fact, if you are able to achieve that, you can shave off years from a research program and arrive at medicine very quickly. Now, if you talk about transparency, permit me that I may take slightly longer than I thought. If you talk about transparency, you want to treat everyone fairly and with equity, transparently. So if you are undertaking your research, for example, through the sovereignty network, you will be able to reach everyone and use their data in an equitable manner on a fair and open platform that no one feels has been dealt a hash card versus the other person. And that transparency, you will be amazed. It engenders strong positivity and goodwill. Now, let me underline that. Goodwill on the side of the researcher and the patient is such a wonderful currency, in the sense that a lot of research and experimentation can be done by both sides, understanding that no one is up to any malice. And when you remove that connotation or feeling of malice, everyone is very open to participating, and solutions are arrived at very quickly. And some instances of bending the rules, I'm not saying bending it in a negative manner, speeding the light to arrive at destination faster, can be attained. If we relate back to the mention where Casey related to patients chaining themselves to the gates of the pharma industry headquarters, it wasn't the pharma industry, pharmaceutical company refusing to grant the patients access to the medicine. It's actually the rules. The regulator demands that the research company must undertake myriads and myriads of types of trials, and since there isn't an accurate tool on the table to help the researchers speed it up, they play safe and say, we dare not give you a medicine until we've proved many things. But in an environment where there is strong transparency, goodwill is rapidly built, and the two parties can arrive at a trial position and say, I do not know everything yet, but I have undertaken everything with the accurate data that I have. I can, in all honesty, tell the regulator that beyond the knowledge that I have now, I still need to build new knowledge, but based on what I have now, I think we can give to deserving cases or desperate cases. And that transparency stands in for all the other missing pieces and creates a goodwill that enables everyone to move forward. I need to emphasize that, but let me move to the point number 4, positive connectivity. Presently, if you want to locate a patient in sub-Saharan Africa who has, let's say, diabetes, and another one in Japan, and another one in the US, you have to depend on standard systems. And you have to hope that each of the caregivers is willing to open up to their data to the other parties. And that is very difficult. And it is the reason why it takes so long to arrive at developing solutions for patients, because there isn't sufficient connectivity that enables every side, patients from all parts of the world or clinicians from all parts of the world, to relate their experiences, their frustrations, their situations very quickly. And also based on that, pick forward on the success situations and build on that and create solutions. We don't have that now. Let me give you an example. There is a company that developed a medicine for diabetes. And it was wonderful. It works very well. It lowers blood sugar very well. It does all the other good things very well. Unfortunately, it had a side effect that led to heart attacks. Now, in all honesty, no pharmaceutical company develops medicine with intentions of killing. But because it takes hundreds or thousands of patients exposed to the medicine for the side effects to become visible, it becomes an inevitability that at some point when the roadblock is hit, all insinuations and difficult conversations happen. But if you had this kind of connectivity that you can easily pick out situations very quickly, they can be put into perspective, or the right reaction can be attained, and alerting all the other patients can be done instantly without waiting for picking data from various parts of the world, cleaning it up, arriving at decisions. All that is unnecessary. When you have a tool like the Sovereignty Network, you can exercise effective, quick, and positive connectivity to advance everything forward. And in closure, let me reiterate again, actually there isn't two sides of the equation to healthcare. If you remove that whole beast called the pharmaceutical companies and relate to the people working in the pharmaceutical companies, they are also patients, or they deal with patients. And when they take away the hat, their pharmaceutical company employee hat, they're just patients or consumers of health services, and everyone wants the same thing for themselves. It's only that so far we've not had efficient, effective tools to achieve the same common goal that we are striving for. Let me pause at that. I realize I've taken long, and I don't know whether you've been hearing me.
We have heard you, Willy, and thank you.
We heard every word, and I was hanging on your every word, Willy. I loved everything you said.
So Willy, we heard everything, and I appreciate your description there. And I want to say to the patient side of whoever's listening is that we as people have gotten so divided We are so into our own spaces and what we're going through, and we fail to realize that what we have and what we can give can help our entire community. And so I think, we really, really need to get together, not on disease spaces, but as people, and really pull together. I see a lot of money being spent in this industry to find certain patients, but as patients, we can talk to each other. Casey can tell you every patient that has this certain condition that she knows of. I can tell you mine, right? We need to use that to benefit our own communities. And so really just combining our efforts and putting together things like this and platforms where we can offer as patient communities what you're looking for without you having to spend the millions of dollars that we're spending on it now. And maybe some of those funds going directly back to these communities that are helping to keep these communities going. And so I want to really quick, before we go, Caroline, I see you, and I want to get Estella's thoughts as she was listening in, because she has a patient group working with lupus patients, who are another group of patients that would be tremendously beneficial, or they would have a benefit from this. So Caroline, I want to get your thoughts. And then Estella, I want to get yours. And then Hamish, I want to really quick wrap it up and see what you're thinking. So Carolina, go for it.
Okay, I have a minute. So when I first started talking to Hamish about the Sovereignty Network, I thought it was brilliant that that patients understood the value of their data. And more than the value of the data is that we've been having a conversation with Christine for a while, that for us, data is the new soil and not just the new oil, because soil is something that really blooms into a solution. And but in order to really bloom into something useful, we really understand what we need from it. What do we need from that data? Because if not, it's useless. So I also worked in the pharma industry, and sometimes, or most of the times, unfortunately, pharma works in silos, and there are people that work in market access, people that focus on patient journey and marketing, etc. And they don't realize that that really patients live a life that doesn't end necessarily with the prescription of a product. The good thing and that Hamish and the Sovereignty Network offers is that you have a bigger picture of what happens to patients that receive different treatments or how they handle different conditions beyond the benefits of a product. And that is what patients are really needing. Patient journey shouldn't be just like a road trip from market access point of view and then the patient point of view. It should be together, and that is one of the things that really really resonated with me when we started talking about how Hamish and the Sovereignty Network is planning on not having only patients being paid for their data, but also mapping it out for it really to bloom into solutions, not only in just one perspective. And to add something of what Willy was saying, I would say that you mentioned 4 things: speed, accuracy, connectivity, and transparency. I think that speed, you should also add resources, because it's not just the speed of clinical trials and all the barriers they have, but we should remember that it was only just until 2017 that a product, it was a medical device, was allowed to be commercialized without having a clinical trial, but using real world evidence. And that is what we're building here. So I just wanted to mention that.
I love that. And I love the fact that it is giving real world evidence as we move through something that we're realizing it's a lot more helpful than we thought it might be. Estella, what are your thoughts as a patient kind of listening in, and this idea that you as the community could really pull together? What are your thoughts?
I think you guys all have said a little bit of things that sparked a lot of questions, right? So one is, a lot of patients don't even understand or know what an ICD code, what a SNOMED code is. They don't understand that when they go see the doctor, there is information built on based on their visit or their consult. It is then entered into an EHR system if there is one, or an electronic health record. If not, it is documented on paper. Then all that information goes somewhere else, right? And the problem is that there's so much data everywhere, and the patient never knows where their data is at. And the patient does not have control of who gets the data, what is done with the data. So I think bringing back that control or that information to the patient is very important, especially when everyone in healthcare, and I have worked in healthcare for over 30 years, is everything's about patient-centric care, better healthcare outcomes, better, driven care based on the patient. And in reality is, we don't see that, right, as patients. So let's bring back that power to the patient. Let's standardize data, because the data, there's no standardized data right now. There's a lack of interoperability within electronic health records systems. And when a researcher wants to or has the ability to start research, it is hard to be able to get that group of patients that they're looking for. Because why? There's no trust. The patients have not been part of the process. They have not been included. And even though patients are equal stakeholders, they are not seen as equal stakeholders. So just, to sum everything up, I think we need to be inclusive. We need to educate. We need to empower and stop the silos. And I think once we do that and realize that we do have that soil, we do have those farmers that are ready to, build and make sure this grows into something, we need to include everyone. And I think we start here, where we start educating, and we just take it from here. And I think it is amazing that we're all doing this together. And yes, we need to bring in the different diseases, because we don't know what we're going to have tomorrow. So having all these silos is not benefiting anyone. And that's really my take.
And I'm going to add one thing to what you said and say that, and take it a step further and say that we as patients are looking for federated data as well. And so we can go into that later on what that means to all of us. And I'm sure we're going to have conversations around that. But we have been at an hour. And I want to thank Casey and you, Hamish, and Willy for coming on. I think, this is something that we need. And I like to, and Willy, I really like the side that you say on the pharma side, there really is no reason why this shouldn't happen. And I do see this as a way to save not only us money, but really to bring that money back to the communities and actually help the people who are living with these conditions. And so, Hamish, I am wishing you all the luck. And Juana over here is in the lupus community. And so she obviously has expressed some interest in how that works for her community as well. So we'll make sure to hook you up. But I think as we move forward, we really need to think about both from the industry and the patient perspective about our data, where it's going, how it's contributing to things, not just ourselves, but our communities as a whole. And so I will leave it with, my little quote that I have is, it's only through collective intelligence and collaborative leadership that we'll find viable solutions that work for us all. And so I want to thank all of you for coming on, and sorry about the disaster in the beginning. I am in DC and about to get on stage here. But thank you all for joining me. And if you have any questions about the Sovereignty Network, Casey, Hamish, Willy, I'm willing to answer questions as well. So please feel free to reach out. It's something that we really would like to get people talking about. Any closing quick 30-second remarks from anyone?
I think just from my end, I want to thank everyone for the opportunity to talk about this. I much appreciate it. The key thing that we believe is, if we can help you build the most valuable data set about you and be able to be in a private community of people like you, so you can discuss in a safe environment, and then turn that around and create a patient registry of your own, of your community's own, that researchers can then find the data they need, we can indeed create that soil to the benefit of the patients and also speed up research. That's what it's all about. So well summed up, Christine. Thank you very much to everyone for the opportunity today to talk about this. Can't wait to
and we're going to have this on a recording. I'm going to cut out the very first part of it, and we'll have that available in case you want to look at it or in case you want to share it with your own communities. So, all right. Well, thank you all for joining us. I'll see you all in a bit, and we'll see you next time. We are actually in 2 weeks, we're going to be talking with Telemedic X. So Noor, who is in the audience, has an interesting idea there that we'll be looking at. So thank you all for being here, and love you guys.
Thanks, everyone. Thanks,
Thank you
Christine.
very much, and
Thanks, everybody.
bye-bye.
Bye for now.
Guys. Thanks.